Hello, everybody. Greetings from IGCP Group and MedTalks. I am Dr. K.K. Agarwal. We are going to be live at MedTalks panel as well as in Facebook. And our speaker will be Dr. Anil Ganju. And we will be talking about
good evening, sir.
And we will be talking about some updates in the field of dermatology, in the field of COVID-19, in the field of what's new is happening. So me, Dr. K.K. Agarwal, now welcomes Dr. Anil Ganju. Let's listen to him first and then we will interact with him.
Thank you, sir. Good evening, friends. It's indeed a pleasure to get in touch with so many people at this moment, difficult times, all of us locked up. Just a moment. Can I, is my screen on?
Yes, your screen is on.
Okay. So I shall be talking about how COVID is affecting our specialty and how we need to keep our eyes open to various possibilities in these difficult times of COVID-19 infection. I would like to thank Dr. K.K. Agarwal and the organizers for giving me this opportunity. And this is what I'm going to take you through. Just a moment. Okay. Now, this disease started as a pneumonia of unknown origin in Wuhan, China in December 2019. And later on, they disclosed that the disease actually was a pneumonia caused by a kind of a coronavirus, which they named as a new or a novel coronavirus. And thus, it came to be known as new coronavirus disease or COVID-19. This virus, like its predecessors, has a predilection to get attached to mucosae in the bronchial pathways or in the conjunctiva. It doesn't have a direct effect, affinity for the skin. So skin is not directly involved. But other systems like the cardiovascular system, the kidneys, the liver, they can also get involved. Now, this disease history is very short, so there isn't much literature available on COVID-19 and skin, direct involvement or indirect involvement. However, in this short period of time, also, there are a number of studies that have come and shown that the skin can be directly affected in the form of development of rashes, etc., which I would call primary cutaneous manifestations of COVID-19. Also, the skin can get involved in a number of ways in the healthcare professionals who are providing services to these patients of COVID-19. And the population at large can be affected not only by this disease, but because of the lockdown, I would say. And these I would call the secondary cutaneous manifestations of this disease. Now, there's a study as recent as late last month, and it has already been published in the European Academy Dermatology Journal, where in the northern Italy, in one of the hospitals, they picked up 148 patients of COVID-19, and they examined their skin for presence of any kind of manifestations. 60 of these patients were excluded from this study because they had a history of taking a new drug recently. So there was a possibility that that new drug could have been causing that rash. So they were excluded. Out of the remaining 88 patients, about 18 showed skin rashes. Now, that would be about 20% of those patients. And these rashes happened in 18%. In 8 of the out of the 18, the rashes happened at the onset of the disease, and rest of them developed them as they were continuing their hospitalization. 14 of the 18 had a maculopapular rash. A maculopapular rash is a diffuse erythema, small papules and erythema all over the body. This is a very non-specific rash which influenzas and including the previous coronavirus drug rash. So we would not be able to say specifically that this rash is specific to this disease. These rashes mostly involve the trunk and healed within a few days, and these rashes were not directly related to the severity of the disease. So even if the disease became severe, the rashes did not become severe, or it could be vice versa also. So it was not directly related. Now, as I said, these kind of rashes are non-specific. But in this COVID era, we have to keep our eyes open, particularly the dermatologists, because a patient with a rash to present for the first time could come to a dermatologist, and he has to keep his eyes and mind open to the possibility that this could be COVID-19, which is presenting with a skin rash and which could develop later on into a more sinister disease, into a more serious disease of the respiratory tract and pneumonia, etc. So if we keep our eyes open to this possibility, even the rashes that come in early, we can alert the patient or his physician that this patient may eventually go into COVID-19 infection. Now, there is a report from a Bangkok hospital also, where a patient of COVID-19 first presented with symptoms resembling dengue. The patient had petechial rashes, he had ecchymosis, and he was diagnosed, in fact, and low fever, and he was diagnosed, in fact, as dengue. But later on, as the patient developed respiratory symptoms and a COVID test was done, it was found that the patient was a COVID-19 infection. So a petechial rash can also be a presenting rash sometimes, which we would never have thought. Now, Dr. Jacobs in the University of California reported a 67-year-old patient of his who had typical symptoms of common cold, of congestion, postnasal drip, etc., shortness of breath. They didn't make a diagnosis of COVID infection. Later on, the patient developed a livedoid rash, which is a livedoid rash is a vascular rash on one of the thighs, and the patient developed blood in urine. So all this happened, and later on, the patient was tested for COVID-19 and was found to be positive for COVID-19. So livedoid rash, which is a typical vascular rash, vasculitic rash, can also be a presenting symptom in patients of COVID-19. Now, besides this, patients of dermatology sometimes have epidermal disruption. For example, oral ulcers, for example, conjunctival ulcers, for example, disruption in the skin in patients of eczema, etc., psoriasis, etc. These patients would be more prone to, getting infection with the COVID virus, because the virus can easily get attached to a eroded surface and get involve the patient. So such patients need to be labeled as patients at high risk or people at high risk, and they need to use preventive measures like masks, goggles, and PPEs, etc. Another important practical concern in the care of COVID patients is the presence of autoimmune or chronic, autoimmune inflammatory disorders. We in skin have a huge chunk of autoimmune inflammatory disorders like psoriasis, atopic dermatitis, scleroderma, etc. These patients usually are on immunosuppressants or biologics, or need to be started with immunosuppressants and biologics. So it was very, it's sometimes a very difficult decision as to whether we should give them immunosuppressants or not. So there were specific guidelines that were developed by our associations. It may be easy to defer the initiation of therapy with immunosuppressants and biologics in a patient, in a naive patient who is suspected of having COVID infection. So you can delay the initiation of treatment. But patients who are already on immunosuppressants, who are already on biologics and have their disease well controlled, it may sometimes be a difficult decision as to whether we have to discontinue the biologic or we have to reduce the immunosuppressant. Theoretically speaking, coronavirus is associated with, with the initiation of an immune response that involves interferons, like it involves cytokines like interleukin-1, interleukin-6 to control the disease. It involves antibodies that are released from the beta cells. So if the patient is on immunosuppressants, so definitely the patient would be more prone to develop a more severe disease. However, it has also been said that if the biologics are suddenly stopped, there can be a sudden storm of interleukins in these patients, and that could lead to more damage in patients of COVID-19. In fact, we do use biologics for treatment of patients of COVID-19 to reduce the damage done to the lungs. Particularly, we use biologics like tocilizumab and sarilumab to reduce the cytokine effect on the lungs and to reduce the post disease sequelae on the lungs, and to reduce the morbidity. So we have to be careful and not stop biologics in all the patients as a blanket, and we have to weigh the risks against the advantages and only take a decision thereafter. So we know that immunosuppressants can cause severe disease, but at the same time, we have to keep our eyes open to this possibility that if we stop them, it may lead to a more severe disease. However, there are particular guidelines laid down by both the American Association, by our parent organization, the Indian Association of Dermatologists, Venereologists, and Leprologists, who specifically say this. Our parent organization, IADVL, says that continuing or stopping immunosuppression in a patient with severe autoinflammatory disease has to be done on a case-to-case basis. You can't give a blanket statement that you have to stop it in all patients. The immunosuppressants patients are at an increased risk of developing the coronavirus disease for sure. Therefore, if a patient is on these drugs and has his disease well controlled and has not got active signs of COVID-19, has not tested positive for COVID-19, you may as well continue with the immunosuppressants and keep a strict watch on the patient. This patient is at special risk of developing COVID-19, so he becomes a high risk patient. So keep your eyes open to the possibility of him developing an infection. The International Psoriasis Council does not recommend discontinuation of biologics in patients infected with coronavirus unless you take a proper assessment of the patient. And sudden withdrawal of the drug can lead to exacerbation of the disease and may not be very advantageous. You should also consider that even if you are discontinuing or decreasing the immunosuppressant, decrease it to a minimally efficacious level, and be careful in immunosuppressants like corticosteroids, because sudden withdrawal can lead to an adrenal crisis. So reduce it rapidly, but don't reduce it beyond, say, for example, 7.5 to 10 milligrams for a few days to prevent the manifestation of adrenal insufficiency. The AAD, or the American Association of Dermatology, has a specific policy on biologics, as I've already told you. In patients who are already on biologics and do not have active disease or are not showing any signs and symptoms of the disease, in those you can continue and keep a strict watch. In those who have developed the disease, you have to discontinue altogether. In patients where initiation of biologic therapy is required, you can, of course, wait and watch and let the disease settle and then start it. Okay. Now, secondary cutaneous manifestations, as I've already told you, amongst the healthcare workers, amongst the population at large, in both of them, there can be secondary manifestations. And one important manifestation nowadays is that we are seeing quite often is development of hand eczema, because all of the patients and the population at large has been told that they have to wash their hands repeatedly. They have to wash their hands for a long time. And they tend to use harsh cleansers or medicated cleansers, which tend to dry up their skin, which can lead to development of eczema. So we have to keep our patients informed about this possibility. They have to avoid harsh detergents. They have to avoid latex gloves as much as possible. And if at all they have to wear gloves, for example, the healthcare professional, they can use cotton gloves underneath. They have to avoid harsh detergent. They have to moisturize their skin after every wash, etc. And if eczema develops, they can go and see a dermatologist. The use of protective gear, particularly N95 masks, has been associated with a lot of contact dermatitis, frictional dermatitis, and rashes on the skin, aggravation of acne, aggravation of seborrheic dermatitis, etc. So this possibility has to be kept in mind. The patients have to keep their skin hydrated, moisturized, etc. The use of protective gears by the medical professional over a long period of time can lead to development of rashes like malarial rash due to excessive sweating, etc. I'm not going to take you through this study where they found hand eczema, nasal bridge involvement, cheek involvement, forehead involvement. This is a recent study from which has been accepted for publication in the JAD, our American journal, where 83% of the 542 healthcare professionals who had been provided a questionnaire submitted their questionnaire answers, and 83% had one kind or the other kind of skin rash. Now, So the take home, skin and COVID-19 interactions, as well as the consequences to the healthcare professionals because of excessive personal hygiene, has to be kept in mind by the dermatologists. They have to be aware of the possibility of COVID-19 presenting as a skin rash, and then warning their physician colleagues that this could be a COVID-19. So be aware of this kind of a possibility. The use of preventive measures like emollients, barrier creams, moisturizers, etc., can go a long way in reducing these manifestations during this pandemic. Thank you very much for your kind attention. I'm open to questions, sir. Yeah.
Thank you, Dr. Anil Ganju. I'm going to ask specific questions, and I'll also check to see on the screen. So what I'm basically asking is, when you say there can be an eczema, and so we normally say that if you decontaminate your surfaces with the 0.1% bleaching solution, then you don't need to wash your hand every 15 minutes or 20 minutes or half an hour. So therefore, you only wash your hand when it is spoiled. So what is the best method? Which soap we should use?
Number one, the lesser we wash, the better better it is as far as the development of eczema is concerned. But use of sanitizers in between is a good way of preventing the dryness that is associated with excessive washing. The more you wash, the more you will cause dryness in the hands. So wash only when it is necessary. And if you have to use a cleanser, you should use a pH balanced cleanser, which is devoid of harsh detergents like sodium lauryl sulfate. So there are mild cleansers available, which can be pH balanced. Also, the skin pH of the skin is 5.5. So if you maintain it around that, the acidic mantle of the skin, if it is maintained at around 5.5, that is associated with less drying, less development of eczema.
See, when we go back to our ancient Vedic philosophy, we used to wash our hand with ash, rock, and the shar mitti. Yeah. And have they been associated with any rash or something? Because they also are good antiseptic.
I don't think they would be as bad as the soap, but it's not only the soap which is troubling, it is even the water. When you are washing your hands, even without the cleansers, the hands or the skin gets the normal natural moisturizing factors get washed away from the surface of the skin. And that can, initially lead to dryness, and over a period of time, it can, evolve into eczema.
The first case in the history of COVID-19 was probably traced back to a person not wearing goggles. He was using PPE, but not using goggles, and it entered through the mucous membrane of the eyes.
Yeah.
So how to take care of the mucous membrane?
The mucous membranes have to be healthy, and have to be protected. There's nothing else that can be done. See, this virus is extremely virulent, and it can attack an intact, healthy mucous membrane easily.
So something like warm water goggles, something like betadine goggles, something like Trifla water, eye wash.
We have been hearing all this. There's no scientific basis for this, though. But yes, we have been hearing that keeping yourself warm, because warm temperatures are not a good substrate for this virus. And if your mucosae are warm and they are kept at a higher temperature, there's a lesser possibility of the virus getting attached to the mucosae. So I do hear about this, but I don't have sufficient
so what's your view? Will the lockdown continue? Personal view.
I think it should continue the way things are worsening over the last few days. I think we are fighting, but the virus is fighting hard too.
The question is, are cleansers as effective as a soap?
Yes, they are. An alcohol-containing cleanser is as effective as the soap, and it is less damaging to the skin than a soap and water wash.
So you can any aggravation in tinea infection in patients who are on sanitizers?
No, sanitizers, no. But yes, you see, in this period of lockdown in general, the patients may not People may not wash as frequently, may not keep their folds clean, may not keep their folds dry, which is important, to prevent and decrease the incidence and recalcitrance of fungal infections in the folds. So that can be a reason of increase in fungal infections. Excessive washing can also lead to candidial infection within the finger folds or the finger webs. So that is another fungal infection. But sanitizers, no, per se, no. But excessive, moisture between the finger webs can also lead to.
If I can't get a sanitizer, what to do?
Then you wash and moisturize. You see, moisturization can be a big way to prevent skin damage. So keep your skin healthy, keep it moisturized, take a healthy diet, follow dictums of healthy lifestyle like exercise, yoga, meditation, good light.
So if I want to moisturize, can I do it with the oil?
Yes, you can. Coconut oil is a very good moisturizing agent. Avoid mustard oil, which can sometimes cause allergies and irritation, and avoid other medicated and fragrance-laden oils. So it's better to use, if you have to, then use coconut oil without any fragrances.
Any symptomatic piece of evidence related to dryness of eyes? Persistent eye irritation. Number 2 is, if a patient presents with a maculopapular rash at this time, is it justified to get COVID-19 test done when there are no other symptoms?
See, as in my presentation, I did tell you that can be a presentation also. So as on now, no, just a maculopapular rash would not be an enough criterion to make the patient go for a COVID-19 test. But at the same time, we have to be careful and keep our eyes and mind open to the possibility of this patient going on to develop COVID-19. So he would be a high-risk patient to be kept under watch, so that if the patient develops any kind of symptoms that are suggestive of COVID later on, then he can be subjected to testing.
Are you taking hydroxychloroquine?
Yes, I have taken it.
You are taking it. And any skin manifestations of long-term hydroxychloroquine?
Long-term hydroxychloroquine can sometimes cause pigmentation of the skin, but the most important, as you know, is the retinopathy. But it usually happens after 6 to 7 months of continuous use. As an acute problem with the hydroxychloroquine can be development of a skin rash, sometimes maculopapular rash, sometimes other kinds of rashes also, like fixed drug eruption, etc.
So I saw a couple of patients on sarcoid who were put on Acicvez. After maybe a year, their whole face became blackened.
Yeah, you can get pigmentation. It's one of the drugs which gets deposited within the skin and causes pigmentation.
Any other thing if you want to add?
I think it has all been discussed, and you have brought out the points that were not discussed very well. Finally, the dermatologists have to be careful.
Anti-allergic is safe?
Pardon, sir?
Which anti-allergic is safe?
I don't think there is any restriction on anti-allergics, but the safer anti-allergics are the non-sedating antihistamines like fexofenadine, like desloratadine, and now we have this belastine, which is a relatively safer out of all of them on most of the systems.
So one answer I'll give: hydroxychloroquine and azithromycin combination is only given in a hospital. You need not worry. That's given in a serious case. And QT prolongation is known for that, but did not worry, because if your QT is normal, then there is no problem for that. And then how can we take care of our hair washing? It is every day with the hospital. Say if I come back from a hospital, should I clean my hair first? Should I wash my hair first?
See, I think you can answer it better. Yes, I think all the healthcare professionals, particularly who are in the COVID wards, should take proper precautions. They have to remove their gear there only in the hospital, and when they come in, before meeting anybody, they have to wash their hands. They preferably have to take a bath and then get into their families.
So, Anil, let's interact with each other. If you want to ask any questions from cardiology or respiratory point of view to me, let's interact.
So, Cardiology, yes. Would you have you come, because we don't see patients? You may have seen patients of COVID. Have you seen patients of COVID with any skin rashes or
Not with
sometimes?
the skin rash, but the day before yesterday, I saw a lady and I did a teleconsultation and admitted her directly to the hospital. She had an influenza-like illness and she died within 36 hours.
Oh my
The
God.
COVID test was negative, but I got a postmortem CT scan done. It showed classical picture suggestive of COVID with COVID negative test. There are cases where we don't know how reliable the tests are, but a patient 60-year, no history of contact with anybody. The only thing is their servant is a Muslim, but the servant vouched that I haven't gone anywhere else because that area is near Nizamuddin. So maybe he came across with another Jamati person and he might have carried the infection asymptomatically to that lady, but no with the skin reaction.
Okay, no skin reaction.
Another question is, should we take hydroxychloroquine and azithromycin as prophylaxis? Answer is no. Only hydroxychloroquine, no azithromycin as prophylaxis. Absolutely no with that. And to prevent milia in PPE wearing SCP, what need to be done?
I think the question would be malaria, which is
Yes.
which is a sweat-induced rash. See, if you are if the healthcare professional is wearing the protective gear, then the longer they wear it, the more there is a possibility of getting a malarial rash. So try and reduce the length of wearing a protective gear, and try and take a bath twice a day and keep your skin free of sweat. And if a little bit of rash develops, the calamine lotion is the best way to treat a malarial rash.
Can I take chloroquine instead of hydroxychloroquine? Hydroxychloroquine is always better, but if it is only twice a week for a couple of months, even chloroquine is fine. And acne, people with sensitive skin or acne, can they use cloth to mask their face if they are allergic to masks? They're talking about the new policy that you can use your scarf or handkerchief or a cloth mark.
Yes, they can. Yes, they can. It is only that if the masks that they are using are causing friction on the skin or causing excessive sweating on the skin, would the acne aggravate. Otherwise, the mask should also not trouble.
And so coming back to cardiology, we have seen, say, Italian doctor who was admitted before. The difference between stage 2 and 3 regarding spread of disease, stage 3 is when you don't know the source. Suddenly you find that cases are happening in the society will be stage 3. A Italian person, doctor who was admitted in Jaipur, and he was discharged on 14th day. A week later, he suddenly died of an acute MI, and that's COVID death. Because COVID can cause myocarditis, COVID can cause low ejection fraction, arrhythmias, COVID can cause atrial fibrillation. So we have seen a couple of deaths because of acute MI in COVID with that. Again, same question again and again, manifestation of skin, sign and symptom that you have already covered, that there are some literature which talks about it. Idiopathic urticaria, how to treat?
Well, idiopathic chronic urticaria is very, chronic and prolonged disease. It needs to be treated with an antihistamine, preferably a non-sedating antihistamine, over a prolonged period of time. We usually give it for about maybe 6 to 8 weeks or maybe 12 weeks continuously, and then try to withdraw it. There are aggravating factors which can aggravate urticaria, like packed foods, like painkillers, like exercise, like alcohol, tight-fitting clothing, like hot water baths, etc., which have to be avoided. And you need to take an antihistamine continuously. That is the only treatment of chronic idiopathic urticaria.
What about hair dyes and COVID-19? Is there any role? Can I continue hair drying at my residence?
Drying or dying? Dying you can continue unless you are allergic to PPD. If a person, there's no direct relation with COVID. If a person is allergic to a dye or PPD, he has to use a non-PPD dye. That's all.
Can we carry out peeling or other dermatological procedures during COVID epidemic?
Not at all. Everything our association has told us to defer all the elective and cosmetic procedures for the time being.
The question for me is, can SCQS be taken after the exposure? The answer is yes. We do give SCQS as a treatment, 1 BD for 5 days, but under medical supervision. It's not it's a scheduled H1 drug. Can I get Dr. Ganju's mobile number, as we have done residency together? And
Who's that?
I will pass it on the number to you. I can't speak it out here. And he hasn't given his name, but he says he's tracing you. So this program is tracing you, one person who has been co-resident with you with that. And what about Chandan?
Chandan, there are cases of Chandan contact dermatitis known in literature, but Chandan you can use. I don't think there's any problem using it.
So will this lockdown give relief to dermatophytosis?
Not at all. You see, in the lockdown, people are not washing properly. They're not following their regular schedule. They tend to lie down in their beds until late in the afternoon. So all this will actually aggravate the fungal infections because the daily routine has been disrupted. They're not washing properly. They're not keeping their folds clean and dry. So there's a possibility that there might be aggravation.
So I want to see the webinar program. We'll send you a copy. How people with severe psoriasis involved with entire body parts should take precautions in this situation with mask and gloves.
Skin of patients of psoriasis, atopic dermatitis, etc., is compromised, and the only thing that they can do is they can moisturize their skin very well. They can use special moisturizers that have a lot of natural moisturizing factors, ceramides, etc., which keeps their skin healthy and resilient to the entry of various organisms. Although COVID does not enter into the body through the skin, that's what the evidence shows, that enters only through mucosa. But still, you have to be careful in patients with a compromised
So
skin.
one last question for you: any fungal information regarding COVID? But before that, can SCQS be taken in asymptomatic healthcare personnel? Yes, ICMR guidelines are available. Correlation of COVID with fungal infection, and that will be the last question.
Okay, I've already said we have not seen a surge of fungal infection as of now. It's too early to say, but the lockdown, the people not following a daily routine of cleansing, not changing their clothes daily, not washing and keeping their folds dry, can lead to aggravation of fungal infections. Otherwise, I don't think there's a direct relation with the fungal infection.
So let me thank Dr. Anil Ganju for this beautiful presentation and interaction, a subject which normally no media is covering, and nobody even in the people are talking about how to take care of your skin during the COVID-19. It will go a long way. Thank you very much for being here with us.
Thank you,
and
sir.
all those people who want these slides can send a request. We'll send you the relevant slides to all of you. Thank you, and COVID Namaste.
Thank you very much, sir. COVID Namaste to you too.